Good afternoon, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. On April 16th of this year, NAMSP announced the release of 3 new EMS model guidelines developed in collaboration with ACOG that focus on pre-hospital obstetrical emergencies, one on postpartum hemorrhage, another for elevated blood pressure in pregnancy and postpartum, and a third about the management of eclampsia. Our topic today is therefore cutting edge. I'd now like to introduce Dr. Lean Samha, our current UCSD EMS Fellow, to present her talk entitled Evaluation of California's 911 EMS Obstetric Protocols. She's prepared this lecture especially for us, with a focus on both the evidence base and the knowledge of what's occurring across the state. We're looking forward to her timely presentation today, which is just one day following a National Association of EMS Physicians town hall entitled Bridging the Gap, EMS Guidelines for Obstetric Emergencies, created as part of National EMS Week. So happy EMS Week, everybody, and over to you, Lean.
Thank you.
So should I mute on
Turn off your audio. Yeah.
Turn off my audio. Perfect. Okay, so I'm going to share my slides. Right. Okay, we're good to go. Okay, so let me just this all right. So I'm going to present so this is a project I've been working on all year throughout my fellowship, where we're just evaluating the obstetric protocols throughout each MUMSA, comparing them to national guidelines, standard guidelines. And so this is California focus in a sense. And so this is probably the most up to date. I had to add in some more. The data keeps changing as we go. More protocols are changing as we go. So this is probably the most up to date I got as of last week, or not even last week, probably 2 days ago. So here we go. Just want to make sure I'm going. Here we go. All right, there's not. I'll do this. Okay, so some background. So there was a report by it's the Nowhere to Go Maternity Care Deserts, and basically what they went through, every county throughout the United States, and they evaluated what was the obstetric access that populations in these counties have. And this really came in light of ongoing increasing obstetric unit closures throughout the nation. Here they found so let's see, just trying to refer that on the next page. So 35% is what they were saying reach up to maternity care deserts. And what this means is that there is no obstetric care within these deserts, and these patient populations have to travel fairly long distances to get their care. And this is a growing number. This report is as of 2024. Within this year, the changes have not been documented quite yet, but there's an anticipation that it could increase. So some causes and related to this, why are we closing down these obstetric units? Budget cuts is a big one, declining birth rates and workforce shortages. And so these are the top 3. There are some other more or less specific to each county, but this tends to be the overall arching theme when it comes to what's going on nationwide. From there, so usually there's like a notes kind of presenting mode, but it's not showing up. So we're gonna go through this. Okay, so within the state of California, kind of made a cool diagram here. So we have every county here. And so based off of the obstetric care within by this report is what I'm going with. So over the last decade, we've had 50 maternity ward closures as of 2024. This is what the report designates as maternity care, low access or moderate access. And we'll go through them each, but we're going to start off with the moderate access. So this is where we have less than 2 obstetric care centers within the county. And then it designates it as the proportion of women with or without health insurance, as well as the obstetric providers. And so the moderate care, which I've designated as like the beach, so there's like some water, some sun, some nice environment in a sense. We've got San Benito, Calvares, I cannot say these counties, but here we go, Yuba and Lake. And so these are considered moderate access as of this report. Now, we have our low access, which I've kind of done as an oasis, a little bit more isolated, here we go, but still, some water, something to survive on. And Imperial County is actually under this low access. Again, this tends to show the report versus like the data numbers versus the actual patient experience, right? So these patients still have to travel very far distances to get obstetric care. So what does low access mean? Is Imperial kind of right on that border with maternity care desert? Possibly. So this is very much just based off the 2024 and just the criteria they're looking at. With maternity care deserts, so doesn't mean it's a full-on desert, no water. We have Glen, Colusa, and Sierra Alpine. And these are with no obstetric providers within that range. And they also include like midwives, family physicians who provide obstetric care within this criteria as well. And so these patients are really going to be relying on long transport times in order to get to obstetric care. And so that kind of brings up the question of terms of what do we have as pre-hospital providers in preparedness for this, because we're probably going to be that first line after this. So just a trend to show the increasing mortality rate. This is up until 2019 in the United States, continuing to increase. This is becoming more and more well documented. So something really terrifying to think about, especially as, what do they say? In terms of quote unquote, a developed country, we are highest in mortality for what that is worth in the article they're saying. There are barriers to getting full data on this, and especially where we're having increasing, So there are barriers in getting the data in terms of pre-hospital obstetric events. So with our maternity, with the maternity care deserts popping up, with the increase that this is probably going to fall onto pre-hospital medicine in order to take care of, we really should be more focused on getting more data to kind of figure out where we need to fine tune everything. And so this is a big thing within the United States. We have missing data. We are not very uniform in how we're documenting these events. So pulling this information is very difficult. We have some evidence-based information on maternal cardiac arrests. Again, very small. And again, these are like 1% of the events that pre-hospital providers will encounter. And then small amount of calls. This probably was more or less from the maybe the COVID era when home births also increased. Still a trend going on that, I haven't looked into the most recent data on what home births are versus in care facility, but something that also will probably increase the exposure to these emergencies. All right, so when they went through and they pulled what are the emergencies in obstetrics that pre-hospital providers tend to encounter. This is what most of the data came up with. This is also including global data as well. So they are infrequent, but when they happen and when they're high acuity emergencies, they're very stressful. So postpartum hemorrhage, breech, cord prolapse, and then prematurity and neonatal death are some of the issues that pre-hospital providers, when they pull the data, are encountering with these high acuity emergencies. This is on a global scale when they surveyed pre-hospital providers and they said, what is the most stressful emergency, you would say, and they said gynecologic, and they put obstetric under here as well. And again, this is on the global scale. Limited data is within the US. We don't really have that full data. But if we are, quote unquote, having very high mortality rates in these maternity care deserts, and we compare ourselves to our colleagues internationally, probably we're going to be right up there as well. So what are some concerns with this? Prolonged transport times. So these patients are going to be under this emergency scope of physiology with our providers for longer times. And so are we equipped to deal with the long transport times? Are we equipped to change with a dynamically changing emergency with these patients? Are providers educated or at least have that re-education or ongoing education for these patients? And then the scope of care. Are we changing our protocols? Are we adding in things in order to have our providers be more equipped to deal with these patients? And one quote that I keep seeing within a lot of these articles is, we know that increased transport times for traumas and high acuity medical cases lead to very, sad outcomes in a sense. And so why is that different for obstetric emergencies? And this is one of our biggest concerns, especially with maternity care deserts appearing more and more, that the transport times are increasing more and more as well. So for this, our national NMEMSCG, I guess, or AMSO. So this is the standard guidelines that is put out there for template that we ended up comparing a lot of our protocols to. And then more recently, this is the with ACOG and MSP got together and created 3 more kind of standardized guidelines for postpartum hemorrhage, eclampsia, preeclampsia, elevated blood pressure. And so we took these as well. And this is where I'm saying the data is constantly changing, the standards constantly changing. And so we took these data and updated it and compared it to what we have within the state of California. And so in this study, we went through the obstetric protocols within each LAMSA, and we compared it to the standard, and seeing, are we comprehensive enough? Are we, making sure we have that scope of care for our pre-hospital providers, as this is a dynamically changing situation. So our methods. All right, so I went to this website. All right, so this is where all the LAMSA links are, and I went through for every LAMSA that has online protocols. This is what I focused on. So if there was an online protocol, downloaded it, went through it, and then we categorized them. From there, we had several categories. So for routine delivery, I categorized into fully described, minimal hands-on, which we'll kind of mention as we go, mentioned routine, but no description, or no routine delivery described. And so just based off of the level of instruction provided, this one can also be, and we'll talk more and more, but there is also that scope of practice that routine delivery is already assumed by our providers. And so we'll kind of see how that changes into the data as well, whether we need to provide that instruction or not. Complicated delivery, same thing. I just based it off of, are we having hands-on maneuvers, transport, and positioning, and what elements of each are we including in the complicated deliveries? So we also looked at postpartum hemorrhage, vaginal bleeding, and preeclampsia, and compared it to the standard, both the NMSO guideline as well as the new ACOG, and as well, what is standard practice? What is the gold standard here? So, and then we looked at, okay, where are our LAMSAs in terms of our maternity care deserts and low access? Which LAMSAs tend to fall, or which LAMSAs fall under these categories? And then we look at their protocols and see what they've included. All right, so for the results. So for routine deliveries, out of 34 LAMSAs, we have 13 that fully described routine delivery. And by that, what I mean is they actually in their protocols have the step-by-step provided, like the step-by-step routine delivery that is provided by the standard guidelines. Again, this data with the variability where you have, 32% that just have minimal hands-on, meaning like they said, maybe just support the head or, support something within it, just some minimal hands-on intervention, but not the full description. And then 9 of them just said routine delivery, that's it. So again, is this assuming that our providers know how to do this because it's within their, their scope of practice? Possibly, but having that referral is also something to consider as well, especially as maybe these are going to be increasing up during transport times as well. For our complicated, so we broke these up into the different types of complications that were presented. So for our breech delivery, it's most of our protocols split breech and then limb breech. So for breech delivery, 33 of the 34 had something to do with how to handle a breech delivery. But that being said, those protocols varied significantly. So majority of them just had maybe one hands-on maneuver, which is maybe like support the limb or support whatever it is that's breeching, and then transport, right? Where 5 of the 33 actually had full hands-on maneuvers, positioning options, transport, and then transport obviously with that. So very significantly variable there. And then even more so when it came to limb breech. So most of them were just position and transport. Very minimal had like hands-on maneuvers and transport. Only 2 had all 3. within our prolapse cord. We did pretty good here in California. That's like really good, right? We're all scared of prolapse cord, clearly. So 94% of all the LEMSAs had something for prolapse cord, and all of them had hands-on maneuver, some type of positioning, and a transport. So great. I think that's really comprehensive. One had a hands-on maneuver and transport. The other just said, transport only, let's go. So something to look at there. For shoulder dystocia, so this one also was very surprisingly that it was very variable. So only 6 LEMSAs had shoulder dystocia protocols, and half of them had the suprapubic pressure, McRoberts, and then, comprehensive from there. And then the other 2 were kind of split between the 2. One just said suprapubic pressure, the other said only position only. And so I think this is especially with long transport times, and especially if we're thinking of who our populations and their health, what really health disparities are in populations that do not have access to care, that this could be something that we need to address more seriously as well and include in our protocols more comprehensively. All right, nuchal cord. So 72% had, so majority had, I think, what I would say is very comprehensive. Slip the cord of the head and then clamp and then cut and then, deliver kid. So the other 2, there was more variability among the rest that kind of were like, some of them were like, just pull the cord over and keep going. And then the other was said, okay, maybe, it was kind of more variable, more vague. And then there was just a slew of randomness of what we're going to include in our protocols across all LEMSAs. And so from here, these are other complications that were included. Oh, I didn't realize that they were kind of cut off. Sorry about that. But, a lot of them were like placental complications. One of them had like intact amniotic sac or I guess 3 of them did intact amniotic sac, and what to do with that. And it kind of goes through, pinch the sac and then deliver the kid. Ironically, only a few had like multiple births, which I was thinking, well, maybe we should include more of that. But, and it just gets a little bit more, variable as we go through those other complications. All right, for our postpartum hemorrhage protocol. So 32 LEMSAs had fundal massage, and that was often integrated into routine delivery protocols, especially if they were there. And then from there, it kind of got more and more variable. So 29 of the 34 had some sort of postpartum hemorrhage protocol. And from there, there's these different kind of interventions that we are putting in our protocols for our pre-hospital providers. Fundal massage is by far the most common. I think that's a great start. For everybody that so there's 5 protocols included oxytocin. And so for everybody who provided oxytocin, also provided TXA, but not vice versa, which is also now included in the newer updates on the guidelines. So something to look at there. Some of them had positioning, left lateral position, saline administration was very common as well. And then from there, the medication administration. TXA is getting more and more popular. That one, that's probably the most updated as well, is that I think in the last, every time I open the protocols, I find someone else who added TXA and I'm like, dang, I have to go back and add the numbers again. So it's a good thing, but it's constantly changing. So that's always a good thing as well. Preeclampsia protocols. So 25 of the LEMSAs had a specific preeclampsia protocol. 8 of the other 8 LEMSAs just referred under the general seizure protocol for preeclampsia, and then 2 had no protocol. And then from there, what we're doing for preeclampsia is also very variable. So majority had just midazolam only. And then from there, we can see there's some of them there's some with like first midazolam, then MAG, and then other ones are like, no, MAG first, then midazolam. And one is finally like MAG only. And so all over the place. And we know that there's a standard treatment for this. And so including that. One did have nitro after, but that was a base hospital order and that was based off of blood pressure. So very, very variable with these treatments. Nausea vomiting protocols, 13 of the 34 had general nausea vomiting. All of them used Zofran. 8 of them specifically into pregnancy, addressed pregnancy specifically, and then they were variable across there. So 4 of the 8 said only allowed in first trimester. And then 2 of the 8 said, no, you're not allowed to use Zofran, it's contraindicated. 1 of the 8 said only if it's prescribed to the patient. And then another was mentioning you can give it to breastfeeding mothers. So very variable across the board. And there are new guidelines on this as well in terms of how to manage it. And Zofran tends to be more of the second line based off of ACOG. And so kind of readdressing this issue as well. Spontaneous abortion protocols. So 6 of the 34 had some sort of protocol for managing spontaneous abortions. And then 5 of the 6 were saying, based off of gestational age. And a lot of them were basing transport criteria off of gestational age. And so what that meant, greater than 20 weeks, you go to an obstetric unit. Less than 20 weeks, go to any hospital. One LEMSA said greater than 1 pound if you can't tell how much by weeks. And I don't know how we would tell by 1 pound. That's just me. I'm very bad at these things. So yeah, I was like, I don't know. Yeah, but so, and then the other 3 provided like guidance on positioning for long transports and things like that in terms of when these are happening. And then we compared, okay, so of the LEMSAs, who are in maternity care deserts, who are having low access. So there is 8 LEMSAs with 1 hospital. So it's either like, it almost seemed like in California it was really 2 extremes. You either had like 1 hospital or you had greater than 6 hospitals. So everybody else kind of fell in between there. And so 8 of those California counties were maternity care deserts. And then of those 8, 5 LEMSAs fall under this. And so some places, some areas of improvement that, I was looking at was the breach protocols where we're just doing maybe maneuvers or transport. Limb presentation, especially, I think it's a little bit more specific and a little bit more variable on what we're telling in these protocols. And then postpartum hemorrhage, especially with oxytocin, TXA, what are we doing with that as well? But we're good on prolapse cord. Everybody has prolapse cord, so we're good there. So I want to compare it to our county protocols. So for our routine delivery, we fall in that 32%, where again, is this assuming that maybe our pre-hospital providers were just assuming that they understand the step-by-step on how to deliver a baby? Maybe. Again, we have at least some discretion on what to do for like the placenta and fundal massage. And so that fell under that category according to how I organized this. Nuchal cord, we're in the majority, 72%. We have full description. We got, slip the cord over the head and cut the cord. So all good stuff there. Prolapse cord, again, we had all 3 elements. We're in the majority there with the 94%. Shoulder dystocia. So we are the 2 out of the 6 that did position and transport only. So we have a protocol. We have some information on what to do with it. But we're not with so the 3 out of the 6 was having also like hands-on where they were going to do like suprapubic pressure and that one. So breech birth was, we were part of the 5 of the 20 with transport only on this one. And then a little bit more. Sorry, there we go. We're just going to go, there we go. Oh my gosh, technologies. Okay, so, and then with the Frank breach, we're the 1 out of the 20 where we're saying no support initially, but then you can support after, which is a unique mention that wasn't mentioned in any of the other protocols. And then we say transport as well. So we have a protocol, that's always great. And then, we can expand on it. So for postpartum hemorrhage, we are in the 17 out of the 32 LEMSAs with TXA. Didn't see any oxytocin within our protocols. And then we are in the majority with fundal massage, which is both included in the routine as well as in postpartum. And then we are in the 38% with midazolam only on the pre-eclampsia protocol. That's where we fall. I didn't see anything for spontaneous abortion or nausea vomiting, so there's potential places for. But again, San Diego also is one of the LEMSAs that has like 6+ hospitals, so maybe there's that component as well with it. Conclusion. So overall, very variable across the state. I think and every LEMSA is going to maybe more or less tailor to what their availabilities of obstetric providers are. But for sure that there's variability, including in the areas where we're having low access. And I think with more closures, we might see even more of those patients coming towards our county, coming towards other counties with higher access. And so knowing that there might be increased transport times coming along as well. Questions, comments, concerns? These are my references.
Thank you so much. Fascinating presentation and very, very timely. We do have a question in the chat from NS. He says, with some of our hospitals, L&D closed and we're not to transfer transport there, in the case of an L&D hospital being far away and one hospital having it closed, which may be across the street, can an emergency department handle a breech birth?
Yeah, that's always a concern as well, right? Especially if you really need that obstetric provider. I didn't look into the like the emergency room specific capabilities of what we're looking at. I mean, that's like a whole different thing in itself, but at the end of the day, I guess that's something to look into when we're thinking of where we're transporting in terms of these long distance transports or close by. It's a good question. I don't have an answer. Kind of scary though, because I'm thinking if I was working and a breach comes in and I'm alone with no obstetric, that's a nightmare. So, absolutely.
Also ask Dr. D'Onofrio for input and maybe relating that to some of the work for EMSC to prepare emergency departments for any basic pediatric emergency. Joelle, can you comment on that, please?
I would love to comment on this. Oh my goodness, so many thoughts. I have been excited to watch Dr. Samha present because she is a renowned presenter in her techniques on education. She's a prior educator and she is hands down the favorite lecturer of our medics. She's been a guest lecturer through our agency, beloved by all. So that was.
That's so sweet.
I'm not let down. That was a fantastic presentation.
The paramedic program gave you the OLA?
Yeah, she won an award from our paramedic school. And she also taught like the 1200 for our city. And they got resounding feedback. They loved Dr. Samha's presentation. So I've been really excited about this. And you didn't let me down. You're fantastic. That was a fantastic presentation. If you said, D'Onofrio, what would you really like to see? I think that the period of time of pregnancy, delivery, and resuscitation of the newly transitioning creature, this alien that's going from a liquid-based environment to an air-based environment, is a very unique period of time that requires two fields of medicine that we don't normally interact with: obstetrics and neonatology. They are specialists, they have specialty equipment, they have special procedures we don't do in the emergency department. And I think that lends itself, just like all the other very specific systems of care, to having its own system of care. I don't think this falls simply within EMSC. I think people tend to shove NRP into EMSC and we tend to talk about OB because there's not a good place for it. But I think we should truly be advocating for an OB NRP system of care that pulls in obstetricians and neonatologists to help us out with these really difficult discussions, like 1 pound. We don't have scales. How do we tell if something's a pound? Like there's all these things and all these issues. I think we should be incorporating our specialists a lot more to help us with our protocols, to look at our cases and to help us improve the system overall. I think we should be looking at it regionally, statewide, and to really kind of like push the needle. This is scary. Our maternal mortality rate should not be this high. I hope that answered your question, Dr. Kay.
Excellent comments. And we did work quite a bit with our OBGYN specialists in the county in developing the protocols. They were extremely responsive and helpful. So thank you for those thoughts. Dr. Dunn?
Two more thoughts, sorry. So maybe like a 5-year plan at some point, it would be nice to have a systems of care that pulls together the OB and the NRPs, because I don't know if you guys know this, obstetrical hospitals are tiered out by 4 tiers. NICUs are tiered out by 4-tiered systems. They definitely have so many subspecialists and different things. Getting the right patient to the right place might involve, we might need more knowledge into where do we actually take them. And then the second comment is, I just learned, I went and spoke with the California State General at one of her sessions. The #1 cause of mortality for women in OB, do you guys know what it is?
Sepsis.
I hear 1 vote for sepsis.
Well, that was based on what I saw.
Hear another vote for hemorrhage. That was going to be my thought. Cardiovascular. So it turns out when you're pregnant, it is the equivalent to running a marathon every single day. And so if you have any cardiac risk factors, if you're hypertensive, if you're diabetic, if you're predisposed, that whole following year of postpartum you're at a significantly increased risk of going into heart failure. And it's really significant. So when the ACOG released the thing about preeclampsia, and we're like, that's not super exciting. It's just high blood pressure. It actually is really significant, and we have the possibility to move the needle. And I think we should also be looking at the year following, at least the first few months following delivery. We should be treating that population of women a little bit differently. In Florida, they're doing such things as putting bracelets on the women after delivery that stay in place. So if they have an event at home, providers know this woman just had a delivery. She's higher risk for stroke and heart failure. So something to think about. And I see Dr. Duncan has his hand up.
Just before he jumps in, add to that, I agree we should be looking for up to after a year of delivery, and also during pregnancy, blood pressure can be lower. So something that we might not consider to be high blood pressure in another patient could be high blood pressure in a pregnant patient. So be aware of that. Dave, over to you.
Hey, thanks, Dr. K. Hey, a comment and a question, Dr. Sama, that was absolutely amazing. Thank you for your work. What an incredible compilation. And I'm going to highlight comparison of all the LEMSAs. And that's going to transition into comment part B, which is K2. I think MDAC and EMSA both need to hear this lecture. I think it would be invaluable. She's done incredible work that we really don't do, and comparing OB response and treatment for all the LEMSAs. I think it would be just invaluable for the state and certainly save lives in the long run if we all knew what we were all doing, and maybe some additional commentary now that we have some consensus statements on where we should be. We've got an MDAC coming up that, I mean, anytime we could get you in for a 45-minute MDAC, I think it would be just invaluable. Question is, I recently, maybe unfortunately, agreed to participate on a board of a rural hospital that discontinued OBGYN, one of the many that you've cited, trying to convince them to crack the doors open, but the dollars don't allow. So the question really is, have you seen successful models with midwives in family practice that can crack open the door for OB? Is there any sort of models or baseline that we could implement in California to help bridge this gap that seems to be growing? Back to you.
So, I mean, through looking at the data for this one, the data for, I guess if we're including like pre-hospital and, that's limited anyway for what we have. But I think especially after COVID, where home births really started increasing, that data is actually probably coming up more and more on, is that something effective? Is it something that's taking care of the issue or not? There was like one LEMSA that mentioned special consideration with midwives on scene in their obstetric protocol. So maybe that's something we can look into and say, is there something we can include on that aspect? In terms of effect, not sure, to be honest.
Our California State Surgeon General right now is an obstetrician. So this is a big thing for her. And she actually, because we talked about EMS at the state symposium, and they brought up a lot about how EMS could utilize birthing centers and licensed midwives probably better, and that there's so many community initiatives that we could probably engage in successfully.
And I mean, they're still considering the desert, like a maternity care desert, as even not having midwives either. So that can also be, I mean, even if we do start including it, how are we going to get them out there? Is that a cost thing? Everything's money.
For education, training, getting out.
Exactly. So definitely lots of venues to look at for this now.
Great discussion. Let me add a couple more points in terms of cause of death. Another thing we should remember is that the incidence of domestic violence, including strangulation, is increased in pregnancy and postpartum. So that's something to have a high level of alertness about. Another point is for pre-hospital blood, which we've talked about, is another hot topic these days. They found in systems where they're doing it that it's not just trauma, But there's a couple of other main uses that hospital blood has been life-saving for, and that's been GI bleed and postpartum hemorrhage. So postpartum hemorrhage could be a condition where pre-hospital blood might be indicated depending on how your system is set up. Dr. Schwartz, did I see your hand up?
Yeah, I was up for a second. This is a very speculative question, but if we're going to have a bunch of hospitals shutting down their OB and prolonged transports that pre-hospitals will be involved with, some of the decision making about where to take somebody and where to divert might be related to, the cervical dilatation, but that's not something that medics do. I wonder if anybody foresees us training them on that in the future.
I'll go with
That's
no.
why I took my hand down. Who knows?
I'm not hearing anybody embrace that question. I mean, the point about, and I think Ennis was alluding to this too, where do you transport these patients? Because they have sometimes complex conditions and not all hospitals have the resources, particularly if you're in a rural area, to manage them. But that's going to depend on how your system is set up and what kind of secondary transfers you have in place and how stable the person is. But these are definitely potentially very challenging cases.
There's also the concern for the political climate. I'm just kind of adding on, if there's changes of political ideas within surrounding states, are we going to start seeing an influx into this area, within our system? Who knows? But there's always that consideration as well, especially because I was thinking the counties that do border, maybe a lot of these states some of them are maternity care deserts or low resource. So, it's how are we gonna manage that as well? Just a thought.
Yeah, and I think we have a good opportunity right now with the state surgeon general being an obstetrician to advocate for some of these changes and some of the standardization that's been put together in the joint guidelines. There's a comment.
Yeah, I mean, the bottom line is it's going to be better to deliver in an ER than in an ambulance. So you have to figure out something.
But if you're in an ambulance moving, you have something like a prolapse cord or like a single foot breach, and you have to do a C-section for this patient, is it better to go to a hospital has an obstetrician, or wait for the mom to arrest so you can do a perimortem like hysterectomy in the ER? Silence is usually what we get.
Yeah.
It's these are hard, and I have these conversations at a lot of places. This is not a San Diego or California specific issue. And it's an issue that's really difficult and painful to answer, so it tends to go silent. It's really hard. I wonder, I wonder, is this conversation going to stimulate possibly addition of oxytocin and magnesium to the scope of practice for this protocol to be able to improve our care of women?
Great question, and I was just going to note that there's a comment about oxytocin in the chat. So Dr. Samha, after your review and analysis, so what are your thoughts on oxytocin and magnesium, and for that matter, other blood pressure medications? Because magnesium would be more for the seizure prevention.
Yeah, so I guess just so I understand the question, the comparison between oxytocin and the MAG different, again, knowing what ACOG has put out there is kind of what I'm also referring to in terms of any practice with this. And so, if the standard is MAG, I feel like that's something that we should consider more when it comes to making these protocols for eclampsia. Oxytocin as well, I think there's a reason I think that it's coming back into guidelines, especially nationwide. And so looking at that, I know there was a comment earlier saying that maybe we had it, but it was not being used because it was expensive to stock, which is also always D'Onofrio. Thank you. So that's always a consideration as well. I know San Diego is maybe more on the quicker, how do I say it? Like there's more hospitals, closer transport times, so maybe that is a consideration there. But I think MAG at least, I don't know, looking at standards, looking at the treatments for anybody, we're always going to use MAG. And so I don't know why there's such variability with that protocol, and I think I think personally, me being, not the speaker of everything standard out there, but I think that that's the standard practice I was taught, and we should be able to consider that, so.
Thank you. Brad Schwartz again.
Yeah, just on the comment of MAG, I do think that's something will be useful to us, because if you think about it, somebody comes into an ER that doesn't have an OB unit, but they're preeclamptic or eclamptic, and they're started on MAG, they're going to want them transported. And it'll behoove us to have that in the armamentarium to be able to continue it.
And thank
But-
you. Jesse points out in the chat that we have some longer transport times, like 90 minutes to get to an emergency department. And that's one of the challenges of our county is we've got rural areas in addition to urban areas and everything else, a border, an ocean, a desert, tribal land, military installations, you name it, we've got it.
I'm learning that real quick. I'm not from San Diego at all. I just moved here. So I'm like, oh, it's very, very useful. Yeah.
Questions for our presenter? I don't see anything in the chat. Dr.
Christian.
Oh, hey, just a reminder, our air medical can transport these OB patients that have prolonged distances like that. So we do have the capabilities with extensive protocols with MAG and things like that available. So that is always an option if you deem it appropriate as a referring agency or hospital.
Thanks for that reminder. What do you have in terms of blood pressure lowering drugs for the air?
Labetalol is what we carry. We also have, I'd have to take a look and see what the latest other stuff that we have, but labetalol for sure.
Excellent, thank you. And good reminder. Any other comments or questions?
Here's an advert. I'm working with the American Academy of Pediatrics right now on a neonatal education for pre-hospital providers that we're hoping will come out in the fall. That specifically takes NRP and turns it into paramedic level training and education. And this will hopefully spin off. My dream is for us to combine with ACOG to actually create a uniformed training that covers delivery, like pregnancy delivery and NRP, but that's probably a few years away.
Excellent. All right, well, thank you, Dr. Samha, for preparing this talk for us. It was very informative. And we appreciate your time. And thank you, everybody, for attending. We'll go ahead and conclude the lecture at this point.